introducing you. So it's a pleasure to introduce Dr. Steve Knapper today, who has kindly agreed to give us a seminar this afternoon. Steve is an academic clinical haematologist at Cardiff University, located within University Hospital Wales, and his expertise is in myeloid malignancies, and in particular AML and myeloproliferative disease. So Steve is a very active clinical trialist with interests in developing targeted therapies for AML and MPD, and is very active in the early phase trials arena. He is a key player really in our Cardiff ECMC and has been steering research in AML from a preclinical through to translational and then into trials as part of our translational pipeline. Steve is also extensively involved at national level through the NCRI, AML and MPD working groups, developing novel trials, and is also the early phase trials program lead for WCRC. And its associate director. So Steve has many roles. We're very busy. So thank you for doing this talk for us this afternoon, Steve. And he's going to tell us about some of the challenges that are facing him as a trialist in AML. So without further ado, I shall hand over, Steve.
Thank you, Jo. That's a very kind introduction. Thanks, everyone, for joining this talk this afternoon. So as Jo said, I am primarily a clinician, so I'm afraid quite a lot of this talk is going to be quite clinically based in terms of acute myeloid leukemia as a disease and some of the challenges of treating it, but I will try to keep it as accessible as possible for the non-clinician. I mean, essentially, in the UK, and particularly centred around Cardiff, we've had a very active clinical trials community in AML over the last few decades, and I'll introduce some of that in the next few slides. And one of the big challenges we've got at the moment is it's almost an embarrassment of riches, with lots of new drugs coming through and lots of new drugs being approved, and the disease becoming much more complex and multifaceted since we've discovered more about the genetics and different subgroups of patients who require different treatments. So some of the fragmentation of that treatment is what's led to the challenges with the clinical trials, but I shall come on to that. So some basics about acute myeloid leukemia. It's a relatively rare cancer. If you look at hematological cancers as a whole, they only make up a relatively small proportion of the whole of cancers. AML is the commonest of the two main acute leukemias. It's certainly the commonest in adults, and there are about 3,000 cases in the UK per year, which breaks down to about 100 cases in Wales, of which we see probably 75 to 80 of them in the south of Wales. It's a disease of older adults. So this graph here shows the way that the age range changes. It peaks over the age of 65. And one of the challenges in AML is that the majority of patients are relatively older and so less able to withstand some of the challenges of some of the more intensive treatments we give for the condition. It typically presents fairly aggressively. The overall ethos of why it happens is that bone marrow precursor cells, blast cells, they proliferate, they fail to differentiate, and they fail to undergo apoptosis. So many of the themes that apply to other cancers apply to AML, and it has this very heterogeneous molecular pathogenesis. The good news is, if you look at these survival curves from actually this is breaking down survival according to the age of the patient. So the older you are, unfortunately, the fewer treatment options you have and the less prospect there is of giving curative treatments. But we have had some breakthroughs in recent years in how we treat older patients with AML as well. This is a slide I tend to use for medical students in my introductory lecture about hematology, but it kind of summarizes some of the clinical features of what happens in acute myeloid leukemia. So essentially, the hallmark clinical features of acute leukemia are due to bone marrow failure. So in other words, they're due to failure to produce red cells, white cells, and platelets. So we have clinical features of anemia, fatigue, breathlessness. We have features of low white cell count in terms of increased tendency towards opportunistic infections. And we have features due to failure of platelet production or thrombocytopenia, and that tends to cause patients to present with bruising, bleeding from mucosal surfaces. We also have an increase in the survival of these early leukemic, these progenitor cells, leading to an expansion of that compartment in the bone marrow, leading to an expansion of progenitors, which sometimes cause bone pain and symptoms of what we call leukostasis. So in other words, sluggish blood flow due to raised count of circulating leukemic cells in the peripheral blood. And the basics of how we treat acute leukemia, this really applies to the top half of this slide, supportive care, really applies to how we treat all patients with AML regardless of age. These are supportive measures to keep patients going essentially and to ameliorate some of the features of bone marrow failure. So red cell and platelet transfusions are a big part of how we keep patients going in the absence of being able to produce these types of blood cells. We use a lot of antibiotics, both prophylactically and in the treatment of opportunistic infections that these patients develop. We also have a lot of very helpful drugs that we can use to mitigate against some of the side effects of disease treatment. So we have anti-sickness drugs, which are very, very important when we're using intensive chemotherapy. And we have drugs to prevent these issues called tumor lysis, which is where cancer cells break down, release toxic metabolic products, and they can cause kidney failure. So we have drugs which get rid of uric acid for treatment of tumor lysis. And essentially the active treatment of AML is still largely based around chemotherapy, but we can use that with curative intent, which we call intensive chemotherapy. And in less fit, older patients, we tend to use treatment non-intensively or palliatively. And I'll come on to that in a minute. And if we're giving intensive chemotherapy, that tends to have to be delivered through some kind of indwelling line. This is a Hickman line, this is a PICC line, and it tends to be delivered in cycles of intensive treatment over a number of months. That's sometimes being followed by with an allogeneic stem cell transplant. And the point of the stem cell transplant is to give patients essentially the donor's immune system, which is then able to achieve what we call a graft versus leukemia effect. The new immunological cells can then act against the leukemia and try to prevent it from relapsing. So that's really the basics of how we manage acute myeloid leukemia. And if we look at the way this really fits together in the UK in a newly diagnosed patient, we really have two types of treatment, which are really like the two sides of a coin. We have intensive chemotherapy, which is applied to pretty much everyone under the age of 60 that presents with the disease, and the fitter patients in the 60 to 75 age range. And this is really aimed at curing the disease, and it consists of a number of cycles of fairly traditional chemotherapy, with these two drugs, daunorubicin and Ara-C or cytarabine, really being the mainstay of this treatment for several decades now. And we sometimes, as I say, follow that with an allogeneic stem cell transplant in patients whom we think are at a higher risk of relapse. On the other side of the coin, we have non-intensive chemotherapy, which is aimed at the less fit, frailer patients. And that is based around controlling rather than curing the disease. And these are treatments traditionally with drugs like low-dose cytarabine and azacitidine, which get given to the patients continuously for as long as the disease is under some kind of control. What used to be called the MRC trials group, and later changed its name to the NCRI trials group, has really been the mainstay in the UK, and was really been the envy of the world, really, in terms of how we've managed to recruit very large numbers of trials into a succession of phase 3 clinical studies over the last 20 or 30 years. And that very much the leader and the figurehead for this group was Alan Burnett, who was the professor of haematology in Cardiff until about 10 years ago. And he led a succession of trials, which, as these graphs will illustrate, particularly in the under 60s, saw a progressive improvement in long-term survival of patients dating from the 1970s up into the present day. But we've still got a long way to go in terms of the majority of patients, even under the age of 60, who are newly diagnosed with AML, still not surviving long-term. The hallmark of these studies is really large numbers of patients treated, so they could be large numbers of patients could be randomized between different questions, and multifactorial randomization was the hallmark of how these studies worked. So one patient could go into the study and have a number of different randomizations to different strains of treatment done as they passed along the treatment journey. so we could ask multiple questions. So more randomizations than patients recruited over time. We've tended to work with Denmark and New Zealand as our two collaborating countries, which means we've had more than 100 hospitals to draw on to recruit patients to those studies. Now that worked well as long as the basic treatment for patients didn't change very much. We've had a succession of studies where all patients could receive essentially the same control treatment, which could then be compared with a number of different novel ways of delivering treatment over the years. And that's really what's changed and what's become a challenge going forward. The other thing which is created a challenge is that we've discovered a lot more about the pathogenesis of AML. We've discovered it's a very heterogeneous condition genetically and mechanistically, and it's actually lots and lots of different genetically divided diseases. This was one attempt made in a seminal review of AML in 2017 to try to impose some order on the genetic subtypes of AML. And really the purpose of this study is to illustrate that it's a complicated heterogeneous disease. So there's lots of different subtypes with lots of different gene fusions, translocations, monosomies underlying AML, and lots of different molecular mutations. The ones that I've sort of boxed in red here are ones where the gene mutation and the pathogenetic effects of it may lend itself to targeted treatments, such as, for instance, FLT3 and IDH inhibitors. So it's a complex disease range, and this slide just illustrates the impact of the different genetic subgroups on how well patients do. So these are the same sorts of patients that were recruited into the MRC trials. This is more than 3,000 of patients, which were characterized by David Grimwade working at Guy's Hospital. And you can see, if you look at long-term survival curves, how heterogeneous they are between different groups of genetic underlying lesions. So these three at the top, we tend to traditionally refer to as favorable risk cytogenetics, going right down to some of these very unfavorable genetic subgroups, such as this line at the bottom, which is inversion 3. If you present with an inversion 3, unfortunately, you only have a 3% chance of long-term survival. So it's very heterogeneous, and it just illustrates the need for nuanced treatment approaches. This is how we classify patients at the moment. This is called the ELN 2017 risk stratification, and we still divide patients into favorable, intermediate risk, and adverse risk disease subgroups. It's very based on the chromosomal changes, the cytogenetics, but there's also incorporation in some of the more recently discovered genetic lesions, the molecular genetic abnormalities. And so it's a sort of attempt to incorporate those various different genetic diagnostic techniques into a classification. But even this is becoming outmoded. We know increasingly that the genetics can change as patients progress through treatment. It's very much a clonal disease. So one patient may have a number of different disease subclones in the bone marrow with different genetic characteristics. So there's a greater move now towards dynamic measurements, dynamic classifications, which allow patients to move between subgroups as we go along. So this is all about illustrating the complexity and the fact that the disease is a bit of a moving target for clinical trialists at the moment. So we've discovered quite a number of very useful drugs which have been added into our treatment armamentarium for AML over the last few years. One of these is this drug Mylotarg, or to give it its official name, gemtuzumab ozogamicin, which is an anti-CD33 targeted chemotherapy drug, which we looked at over a generation of UK AML studies. And this is a meta-analysis that Robert Hills, working in Cardiff at the time, performed, looking at how different cytogenetic groups of patients did in the trials, either with or without Mylotarg. And what Robert's work and the work of the MRC study showed was that the favorable risk group do a lot better if you add Mylotarg to their chemotherapy. The intermediate risk group do a little bit better, but unfortunately it makes no difference whatsoever to treatment of adverse risk patients. So this was the first of a number of drugs which was approved by NICE in the UK for use in the NHS, added to intensive chemotherapy, but only for these groups, the favourable and intermediate risk groups, where it's been shown to provide some benefit. CPX-351 is another drug which we've added to our armamentarium recently. This is actually a combination of just the traditional two chemotherapy drugs, cytarabine and daunorubicin, but they're given in a slightly fancier way, in which they are enclosed within a liposome, which gets incorporated into the AML blast cells and the AML cells in the bone marrow more efficiently, achieves a better pharmacokinetic profile. And in this phase 3 study, which ran in different countries around the world, it was shown to benefit the subgroup of AML patients who had what we call secondary AML. So this is AML that is caused by previous chemotherapy or by preceding hematological disorders like myelodysplastic syndrome. So that one was approved for these subgroups of AML by NICE at about the same time that Mylotarg was approved, so in about 2018. Third group of drugs, which I've been involved in quite a lot of lab and clinical research over the years for, are these group of oral tyrosine kinase inhibitors called FLT3 inhibitors. So FLT3 was one of these mutations that has been known about for a number of years in AML. FLT3 is a tyrosine kinase, which if it's mutated, it gets activated. And about a third of patients with AML have a FLT3 activating mutation. And we know those patients are at an increased risk of relapse compared to the patients who don't have a FLT3 mutation. So a lot of different tyrosine kinase inhibitors with activity against FLT3 have been developed. The first one of them, midostaurin, was shown in an international randomized study looking just at patients with FLT3 mutations to improve overall survival. So this has been added to chemotherapy now for patients with FLT3 mutations. So you're beginning to see different subgroups of patients based on clinical trial results in the last few years are getting different drugs added to their treatment options. The drug which has really been a game changer over the last 12 months, though, is this other oral drug, which is also used in a number of other hematological malignancies, called venetoclax. This is a BCL2 selective inhibitor. So many of you will be aware that BCL2 is an anti-apoptotic pro-survival protein that's overexpressed in a number of cancers and is one of the mechanisms that allows cancer cells to evade apoptosis. AML is no exception to this. It's highly expressed in AML cells, including the AML stem cells, which drive the disease in the bone marrow. So it's been a natural drug to potentially add to AML treatment regimens. And a couple more important clinical trials that have been done around the world in the last few years have looked, this is now looking at the non-intensive, older, frailer patients. And you remember there were a couple of drugs we use in that setting, which are used to try to extend life rather than cure the disease. And venetoclax has been added into both of those treatments. So low-dose cytarabine and azacitidine. And again, I'm sorry to show so many survival curves in this talk, but basically the take-home message from this slide is that venetoclax, if you add it into low-dose chemotherapy, it improves rates of remission and it improves long-term survival, to the point where it's almost competing with the results we're seeing with intensive chemotherapy in this setting. So venetoclax was one of a number of drugs. We've mentioned 3 of them already, and we've now mentioned venetoclax as well, that have been approved by NICE for use in the UK NHS over the last 3 to 4 years. There's a number of other drugs which have also been approved in the US by the Food and Drug Administration, the FDA. That includes drugs targeting IDH1 and IDH2. That's another 2 kinases that are mutated frequently in AML, and a couple of other drugs as well. So we've got a whole range of new sort of toys to play with in AML. But what this has led to, both with the heterogeneity of the molecular different subtypes of AML and the range of new drugs that have been approved, it's led to a fragmentation of how patients are treated. So I've kind of updated my algorithm here to try to show how this is impacted on how we treat patients at the moment. So you'll see it's become a lot more complicated than the slide I showed you a few minutes ago. So we've got the FLT3 group. This is the intensive treatment options. We've got the FLT3 group that now get the addition of the tyrosine kinase inhibitor midostaurin. We've got the Mylotarg going into patients with non-adverse risk cytogenetics. And we've got the liposomal chemotherapy drug going into patients with, a lot of the patients with adverse risk cytogenetics. Not only that, we've also got venetoclax now being given to the patients with non-intensive treatment. And that's actually made this dotted line, well, it's made this line dotted rather than solid because it's slightly blurred which patients we give non-intensive and which patients we give intensive treatment to, because some of the less fit, previously fit patients might actually be better treated with venetoclax options. So there are lots and lots of things to think about now. So it's suddenly become a fast-moving field. And this slide just illustrates some of the different other novel agents which are being developed and have got as far as clinical studies in AML. These are all drugs, well, these are all targets, and these are all drugs which are being used to target them that were all presented, particularly in early phase clinical trials at the Worldwide Hematology meeting, the American Society of Hematology, just before Christmas last year. And the right-hand side of this slide just illustrates there's a whole load of different immunotherapeutic approaches which are also being applied in AML. So some of these are relatively basic immunotherapeutic approaches like the chemotherapy antibody conjugates I've already mentioned, but there are some slightly more sophisticated approaches coming through now, like T-cell engaging antibodies, tumor vaccines, and CAR T therapies, which haven't got as far as AML as in a number of other hematological malignancies. So it's a very, very active field for the clinical trialist, but we're almost sport for choice in terms of how to look at all these drugs at the same time. So what are the challenges? Well, as I've said, AML is genetically and clonally heterogeneous. So the patient treatment algorithms are increasingly diverging. There are lots and lots of targets and lots of agents under development. And we know that the targeted drugs, rather than now being potentially applied to the thousands of patients with AML that the MRC trials have treated traditionally, they may only have niche targeting, and that is more difficult then to generate the required numbers of patients you need for a randomized clinical trial. We know that some of these drugs, especially when we've used them as monotherapy, if you use a FLT3 inhibitor as monotherapy, it doesn't really work. So you really have to be able to combine them early with conventional other drugs to give them a chance of working. And we might need to increasingly think about being more imaginative with which points of the disease treatment course we apply these novel therapies. So traditionally, we've tended to chuck these drugs in at the point where a patient is first diagnosed, or later on, especially with early phase trials, at the point that a patient relapses. But there's a whole journey in between that. So some of these drugs might well lend themselves to being used in maintenance treatment. In other words, to try to prevent a patient from relapsing after they've completed their conventional treatment. Alternatively, we've now got this whole industry around MRD, or measurable residual disease. This is where we use different techniques to measure disease at a very low level in the bone marrow and try to either detect disease which is left behind at a low level after a patient has finished treatment, or detect very early relapsing disease and be able to target it with treatment before it gets to the point of full-blown relapse. So we're increasingly looking at interventions that can be applied at those sorts of time points. This slide just illustrates a couple of techniques we have to measure residual disease in AML. We can use immunophenotypic flow cytometric techniques, which identify the sort of identity of the leukemic stem cells and try to differentiate them from ordinary blasts in the bone marrow. We also have qPCR-based techniques where we can follow molecular events which are detected at the point of initial diagnosis and measure them at a level several logs below what we can detect looking down the microscope at the bone marrow itself. We know from previous MRC trials that molecular MRD is incredibly powerful in terms of differentiating risks of relapse between the different groups of patients. So this slide illustrates one of the particular MRD targets we've used a lot, which is called the nucleophosphamine 1 mutation. This is found in about 35% of AML patients at diagnosis. It's actually the commonest of all the mutations associated with disease. And in the AML17 trial, we did a lot of work looking at thousands of samples to try to work out which the most useful points in the treatment journey to look at the NPM1 levels were. And we showed in the study that if you look at patients after course 2 of chemotherapy, whether you can detect NPM1 still in the peripheral blood or not, as it is very powerful in determining how likely a patient is to relapse. So we risk stratify patients in terms of how we treat them now based on these NPM1 levels. We've also used immunophenotypic flow cytometric MRD, which is very, very predictive. This was the study in the over 60s population treated intensively. We know that if they are MRD positive after course 1 of chemotherapy, they're much, much less likely to survive long-term than if they're MRD negative. And so our current study, which is called AML18, we're doing an extra randomized treatment intensification for those patients who are MRD positive after cycle 1 of treatment. So this is an example of what we call a risk-adapted study design, where treatment can be intensified after the first course to try to give these patients an extra hit with different chemotherapy drugs they haven't been previously exposed to try to get them into a deeper remission. So we're going to have some results of that fairly soon when that trial is due to close at the end of this current calendar year. So where are we now? Where are we now? And do we have any ideas what we're going to do with these clinical trials going forward? So what we have illustrated in our national UK trials over the years is that patient numbers are a really major strength. And that is only achievable by keeping trials organized in such a way that they're manageable at a large number of sites. We're not all big academic sites. There are lots of smaller district general hospitals in the UK and New Zealand and Denmark treating AML patients. So we need to keep these trials accessible. We've previously yielded most of our important research findings from questions which are posed at the point that the patient is first diagnosed with AML. So we'd like to continue to ask what we call induction questions, because we've found that asking questions later on in treatment can be less easy to generate the numbers of patients we require. We know that, especially for some of these targeted agents, translational lab studies, so-called back to bench research running alongside these studies with pharmacodynamic markers, as Joe has been very involved in the past, can add significant value to the results of these targeted interventions. So we're very keen to continue doing that sort of thing. And we're very big on these minimal residual disease assays in the UK. We're still we're considered as world leading in that area. So we're very well placed in the UK with our network of labs to be able to utilize this technology and use these sorts of interventions in the design of clinical trials. It's really important when we've got such a range of drugs to choose from that we try to pick winners at the beginning of the trial, because when we pick a new drug for a trial, we're really committing to potentially investigating that drug for a number of years from that point onwards. It's a very challenging environment, particularly in 2022. Some of this is COVID related. So our traditional grant holders they've had less funds going into them over the last 2 or 3 years, and they have big uncertainties around the clinical trial portfolios they're funding. And it's a very, very competitive market for getting investigator-led clinical trial funding at the moment. These clinical trials are really predicated on really pairing up with the pharmaceutical industries. The pharmaceutical industry also is quite reluctant to invest in very long-term projects at the moment. They're always looking at the bottom line. They're looking at study designs that will potentially widen the market for their particular drugs. And they're also obviously not keen in putting funding into duplicating clinical trials that are being done in other parts of the world. And they're also increasingly concerned with generating what we call registration quality data. These are the sorts of clinical follow-up data on patients in studies that require a lot of money spent on site monitoring visits, collecting forensic level toxicity data to the point that it can be approved by institutions such as the Food and Drug Administration in the US. And that's traditionally what we've not been able to generate with our mass participation studies in the UK. So we've got a real challenge with that at the moment. COVID has inevitably delayed the recruitment to the current generation of studies, so it's moved back the timelines of our new studies a little bit. And there's also these issues around things like venetoclax blurring the traditional demarcations between intensive and non-intensive treatment, and some of the general philosophies about how we organise treatment. So it's been a massive challenge for the AML trials community over the last 12 months, really getting our ideas around how we predict what the next 4 or 5 years hold, doing something which is conducive to keeping our partners on board, getting grant funding, keeping the pharmaceutical industry happy, and backing winners in terms of future-proof drugs. And this is kind of where we are with all our various different partners at the moment. It's a very, very big challenge for everyone. So we're calling, imaginatively, we're calling our next trial AML20. But I think what is becoming increasingly certain is AML20 isn't going to be one single mass participation study like all of Alan Burnett's preceding studies. It's probably going to be a suite of different studies aimed at different subpopulations of AML patients. We're not going to be able to define it by age. In fact, it's becoming non-politically correct to split patients according to age now. We should really be splitting them by biological fitness for treatment. And NICE is very big on that. And most of the drugs which gets approved by NICE, they do it in an age agnostic way. So they're not limiting drugs to patients of certain age groups. So we need to continue to formulate attractive induction questions, incorporate rapid molecular genetics to subdivide patients according to their molecular groups at trial entry. And that's no mean challenge when we're dealing with potentially 80 or 90 different sites around the country. We need to access the right drugs, which are future-proof, and we need to harness our MRD expertise. So where are we at the moment? We've got a number of different active plans that are in process of being organised. These are not all being done through Cardiff. It's a sort of national effort. I'm involved quite a lot in the overall design of this kind of suite of studies, and I'm more involved in some of these different areas that are under exploration than others. And in the last few minutes of this talk, I'm going to kind of walk you through some of the ideas we've got at the moment and how we're wanting to take this forward in the next few years. So we have a number of plans which are pretty active now and will likely lead to funding applications for studies within the next 2 or 3 months. And we also have a number of slightly more, shall we say, early stage applications and trial concepts which are currently being discussed. What I think we're going to have to come up with is some kind of general study platform that allows all of the newly diagnosed patients at centres around the UK to be entered into a sort of study platform which allows us to collect their samples, work out what their different genetic subgroup is, which will then open them up to which of the different kind of suite of genetic group determined studies they can then be considered eligible for. So it's vitally important to be able to collect these patient samples for translational research basis, and also so we're not losing patients and we're really maximising recruitment to the studies we do have open. There are a number of ways we can potentially intervene without necessarily genetically subtyping and using special drugs. So there may be some of the supportive care questions like transfusional thresholds, antibiotic prophylaxis to use, etc. Studies around gut microbiomes, which might be manipulable, that might lend themselves well to supporting type questions. One study we have opened recently, which illustrates some of what we might be able to achieve in different subgroups, is called the Victor study. This is a study that's being led by Richard Dillon at Guy's, and I'm the co-investigator for this study. And it's an example of a study which we're using just where we're recruiting patients in the NPM1 mutated subgroup. And it's really a potentially practice-changing study, and it's the first study that's been done for several decades where non-intensive and intensive treatment approaches are being compared in the same study population. So we take patients with NPM1 mutated disease We know that this patient group has been shown in the venetoclax studies to do exceptionally well with non-intensive treatment where venetoclax is combined with low-dose chemotherapy. What we don't know is if this is equally efficacious to traditional intensive chemotherapy in this subgroup. What we know it's a lot easier to give. These patients can be treated out of hospital with much less toxic treatment. So we're taking patients with NPM1 mutated disease who are aged over 60, and we're randomizing them between intensive and non-intensive approach. And as I've mentioned already, NPM1 is a target that can be measured very, very effectively by minimal residual disease. So if patients are having a less than optimal response in the non-intensive arm, they could potentially switch across to getting intensive treatment as well. So it's an imaginative trial design that, if it works well, that can be then used to extend that to patients under the age of 60 in the future as well. It wouldn't be ethical to offer that sort of low intensity treatment to younger patients just now. We know that venetoclax can be combined with intensive chemotherapy as well. This is a data presented by the MD Anderson group at ASH just gone, which shows exceptionally good response rates and overall survival when venetoclax is combined at the point of new diagnosis with intensive chemotherapy. And I'm going to whiz through these slides quite quickly, but we've got some buy-in from the company that makes the venetoclax, AbbVie, and the company that makes CPX351, Jazz, to run a randomized study where patients who are newly diagnosed and fit for intensive chemotherapy and don't have some of the genetic subgroups which would hive them off into different sorts of treatment will be going in and getting randomized between CPX351 with or without venetoclax treatment. So this one is likely to be funded heavily through pharma industry money, and there's a trial protocol currently being written for this so-called CPX Ven proposal. As I mentioned on my slide summing up lots of drugs available at ASH, there are a number of different immune checkpoint inhibitors that are being looked at in AML. Perhaps one of the most exciting is this macrophage immune checkpoint inhibitor, magrolimab, which is an anti-CD47 antibody, which essentially switches off this so-called do not eat me signal, which AML cells express, which when expressed prevents them undergoing macrophage phagocytosis. So there have been a number of studies with this anti-CD47 antibody, magrolimab. Again, data presented at previous ASH meetings, this time the previous year, has shown magrolimab to be very effective when combined with non-intensive azacitidine treatment. And it seems to be effective in some particularly bad performing genetic subgroups of AML, particularly AML that's associated with a TP53 mutation. And they saw some very impressive remission rates. And it's even better if you combine it with our friend venetoclax. So if you combine azacitidine, venetoclax, and magrolimab together as a triplet, as the MD Anderson group, who else did at ASH just gone, they're now seeing really impressive overall response rates of approaching 90% in TP53 mutated patients. So this could be something that actually is better than traditional intensive chemotherapy for these TP53 mutated patients. So Gilead, the company that own magrolimab, are working with us at the moment in a randomized study in newly diagnosed patients with adverse risk AML or older patients with any non-favorable risk AML, where we're going to randomize patients between standard chemotherapy and this triplet of venetoclax, azacitidine, magrolimab. That will initially be a 160 patient study run in some of the larger centers who are able to collect this registration standard data. And that's something, again, a clinical trial proposal and protocol is being written at the moment. Third proposal for patients with who are fit for intensive chemotherapy is the fact that I touched on earlier on, and I'm sorry to cover so much in this talk, but the fact that patients with newly diagnosed disease may now be approved for these two drugs, Mylotarg, that's the CD33 antibody, and midostaurin, that's the FLT3 inhibitor. Unfortunately, some patients would theoretically be approved for both of these drugs because they're FLT3 positive and have non-adverse risk disease. The problem is you can't actually combine them together because there aren't any safety data to allow you to use them in the same patient at the same time. So we used the tail end of our recently closed AML-19 study to collect safety data on this. We treated 77 patients with a combination of chemotherapy, Mylotarg, and midostaurin, the imaginatively titled Midotarg combination. And we showed it's safe, and we're going to be presenting that data at the European Hematology Association meeting in June. It seems to work very well. And so we're now, I'll come on to what we're going to do with it in a second. There's another genetic subgroup of patients who have good risk disease called core binding factor patients. They do so well with Mylotarg. This is the Robert Hills meta-analysis I referred to you at the start of this presentation, that we're now at the point where we may actually be able to start de-intensifying treatment for some of those patients. In other words, removing drugs which might cause long-term toxicity. One of the drugs we use in cancer treatment, which can cause long-term cardiac toxicity, are drugs called anthracyclines. So what we're wanting to do now in this favorable risk subgroup is removing the anthracyclines from their treatment. So just to show you the most complex trial design I've shown you so far, this is a design which Charlotte in the Cardiff CTR is in the process of designing with us, which will allow newly diagnosed patients in 2 genetic subgroups to be entered and have a randomized induction question to be asked. So we're quite excited about this as a new trial design, which will be one that can be rolled out to all of our traditional cooperating sites. So patients with newly diagnosed AML get screened genetically with a fast turnaround genetic screen. The 25% of them or so that have FLT3 mutations, we can ask this question about the Midotarg regimen. So they can either get DA chemotherapy with midostaurin with or without the addition of Mylotarg, and to see which of those does better. In the 12% with these favorable risk cytogenetic abnormalities, we're going to look at randomizing them to remove the anthracycline from their chemotherapy. And we're going to build into that part of the study some echocardiography to look at cardiac function to see if we're sparing that group from cardiac toxicity. Finally, this is what I'm working on at the moment with a grant application, which is hopefully going in next week. One subgroup of patients with AML that I've not mentioned all the way through this talk so far is an offshoot of AML we call acute promyelocytic leukemia. So APL, as it's otherwise known, accounts for about 10% of patients with AML, and it's managed very, very different to the other 90% of patients with AML. We've known for several decades now that this subtype of AML is caused by the 1517 translocation, which causes a fusion protein called PML-RAR alpha. And that causes an abnormality of the retinoic acid receptor, which causes a block in cell differentiation. So you get a multiplication of promyelocytes in the bone marrow, and that is clinically relevant because it causes a very high early hemorrhagic risk. And a lot of these patients, unfortunately, die from hemorrhagic complications such as intracranial bleeding early on in their disease course. The good news, though, is this is one of the sort of paradigms for the success of targeted treatment in cancer. So retinoic acid, if you give all trans retinoic acid, an analog of retinoic acid, and you add that in to chemotherapy, you can make a massive difference to the outcome for these patients. So this has been ATRA treatment. All trans retinoic acid has been around for about 30 years now. So it's one of the first examples of a successful targeted treatment in cancer. Not only that, we then added in another targeted drug called arsenic trioxide, not given like this, but in our AML-17 trial, we gave non-chemotherapy treatment. So in other words, arsenic trioxide in combination with ATRA, no chemotherapy at all, and compared that with patients getting chemotherapy and ATRA. And we saw that we're now getting virtually 100% long-term molecular disease-free survival in patients who get frontline intravenous arsenic trioxide treatment. It was approved by NICE 3 or 4 years ago now, and is now the mainstay of treatment for the majority of patients who are newly diagnosed with APL. So if we can get them through that first couple of weeks of clotting complications, they're almost without fail surviving long term. So it's a massive success story. Unfortunately, it involves upwards of 60 intravenous infusions, and it requires patients to come backwards and forwards to haematology day units on a regular basis for about 9 months of treatment, during which they can't really do normal things. They can't go back to their jobs. They can't resume normal activities. So there's a big push now to ways of giving oral arsenic trioxide. This is one of the oral arsenic trioxide drugs that's been invented. It's called Arsenal. It's actually made in Hong Kong, but it's shown really remarkable rates of molecular remission in patients getting this drug orally in combination with ATRA treatment. What it's not had yet is a randomized study to assess its success, and it's not had any studies outside Southeast Asia yet. So we've worked in collaboration with the Hong Kong team to design the Ovation study, which is subject to a grant application, which is going in next week. We've got buy-in from all the AML treating centres around the UK, and also our traditional partners in Denmark and New Zealand to participate in this, which will be our first frontline UK study for acute promyelocytic leukemia since AML 17 closed about 7 or 8 years ago. So we aim to randomise about 200 patients with newly diagnosed APL. It will take about 3 to 4 years to recruit this number of patients, and subject to successful funding, we hope this study will be launched at some point in the middle of next year. So basically it's a design where patients newly diagnosed get randomized to either intravenous or oral arsenic treatment, which they get during induction, and then over 8 or 9 months of consolidation courses. And what the study is essentially trying to demonstrate is these patients do just as well, i.e. they're non-inferior in their responses to if they were just getting oral, if they were getting intravenous treatment, but also we can demonstrate big improvements in quality of life, return to work, and also a huge amount of cost savings to the NHS with giving the treatment orally as well. So this is my final slide, just to sort of recapitulate some of what I've said over the last 45 minutes or so. We're obviously suddenly doing really well in APL with drug treatments, which have really revitalized our therapeutic landscape. So there have been at least 5 new drugs approved in the UK over the last few years, but it's created a complex, highly challenging environment for setting up new clinical trials. And we've got to be imaginative and able to predict the future in how we design these trials going forward. We need to be imaginative about the time points that we're applying some of these drugs, including using them in low-level minimal residual disease scenarios. And what we're really headed towards now is a bespoke genetic risk stratification of patients, where we get personalized treatment algorithms that are defined shortly after diagnosis, but may change as they go through the timeline of disease treatment. And we've got to be nimble and ready to move with that going forward. So I'm going to stop there. I thank my colleagues on the AML working group, including colleagues in Cardiff and in the Cardiff CTR as well, and all the various patients, research teams and patient families who've helped with us with the MRC and NCRI trials over so many years. Thank you.
Great, Steve. Thank you very much for that very thorough overview of all those trials that you've got going on. So it sounds like you've got a lot to deal with at the moment. I'll open the floor for any questions. We've got one already in the chat box from Kate, who is asking about magrolimab being trialled in other pathologies. I think what she was getting at was, does it have adverse side effects for its sort of macrophage activities, such as neurodegeneration and microglial death?
Yes, thanks. I'm not absolutely sure. I've not heard about it being used in that context. I mean, it's being looked at in a number of different hematological malignancies as well, like myelodysplastic syndrome, and it actually has been shown to work quite well in the context of lymphoma as well, where it's been combined with chemotherapy recently. One of the interesting things with magrolimab, and it's something that's kind of slightly slowed down its development in the last few months is that CD47 is expressed on quite a lot of red cells as well, especially aging red cells. So if you're not careful, when you first give the antibody, you can get a sudden hemolytic reaction, and you've got to be very, very careful with building up the dose slowly and being prepared to transfuse your patient's red cells early on in the treatment. So it's got its challenges, but it does seem to be one that's going to be a potential game changer going forward.
Yeah. Okay, it looks like a few messages are coming in through the chat. I will just say you can raise your hand if you at the bottom of the Zoom function, and I can give you access to speak as well if you'd like. But another question from Ian Thomas then. Great talk and exciting, challenging times. The very frail patients who receive supportive care only, what percentage of the AML population is this? And what clinical and non-clinical questions can we ask in that context, in that population?
Yeah, thanks, Ian. That's a really good question, because unfortunately, however much we try, the AML trials always end up heading towards the patients who are fit enough to have some kind of treatment. And we all know, I showed you that age incidence graph right at the beginning. We all know that there are significant numbers of patients over the age of 80 and beyond who really may not be treatable with any meaningful treatment. I mean, I saw a newly diagnosed 87-year-old in clinic this morning, and where we're talking about supportive care only. But because those sorts of patients don't tend to show up in clinical trials publications very much, we're not very good at defining really how big that population is and defining really meaningful questions. So this is where some of these supportive care questions really come in. And some of the oral, more targeted treatments may well actually be suitable for these sorts of treatments. I mean, we've got a new approved FLT3 inhibitor called gilteritinib now, which is given orally. And we know that some of these second generation FLT3 inhibitors are so well targeted that what I said about these drugs working as monotherapy may not necessarily be true. So there may be some of these very targeted new drugs, if you pick the right patient for them, even the older, frail and not fit for chemotherapy patients, we might be able to intervene and do something for these patients. So I think we need to always bear this treatment population in mind. You see there's a question from Richard Adams, how variable are treatment regimens around the world? Well, that's, yeah, I mean, you know how much politics there is in this, Richard, and there is a lot of sort of different national trial groups tend to believe in their control arms, and that there is quite a bit of variation in terms of what's approved and what's not approved. And the pharmaceutical industry tends to gravitate to what's approved in the US. So for many, many years, we've had this control arm, which they've used in the US called what they call 3+7, which is daunorubicin and cytarabine, but given at much lower doses than we give in the UK. So all of these studies have to be treated with a pinch of salt. You have to really dig down into what the control arms are. And yeah, it's that herding cats thing again, in terms of how we try to involve, especially when we're trying to do an international study with different collaborating partners, there's always going to be arguments about what the control arms are, what supportive treatment you can give alongside the treatments. And obviously the pharmaceutical industry are always worried about the bottom line and which market for dosing is the one that's going to end up selling the most of their drug. So incorporating variations of different countries is really tricky. It's another thing we need to do, especially as we're getting into smaller and smaller disease subgroups where it's more and more difficult to generate the numbers of patients required for trial in one country alone. I can see there's a question from Oliver. With all the new drugs, are indications for stem cell transplant in CR1, that's first complete remission changing, and what about post-stem cell transplant maintenance? So yeah, so that's certainly right. So I mentioned at the beginning of the talk that some patients we treat with an allogeneic stem cell transplant, and traditionally we've sometimes used that stem cell transplants. Unfortunately, they're the best treatment that's ever been invented for acute leukemia. because they're the best treatment ever for reducing the risk of relapse, but they come at a price of toxicity. And unfortunately, there is a mortality rate associated with doing an allogeneic stem cell transplant. So it's all about weighing up risks and benefits and picking up which patients in first remission have the odds in their favor. And in those patients, we would generally avoid putting them through a transplant, and other patients where we know their risk of relapse is high enough to justify putting them through a transplant in first remission. So as the different drugs become available, and as we get different ways of delivering treatment, these odds will vary. So for instance, there is a new drug called oral azacitidine, which is now being used quite successfully as maintenance treatment. And that's going to be another one that's going through NICE assessment in the next few months, which might potentially mean that some patients get that treatment rather than having a transplant in first complete remission. So again, it's a constantly moving playing field, and it's something where we've just got to try to be wise to what's going on and try to predict constantly what's happening 1 or 2 years ahead when we're planning a trial that's then going to work, that's then going to last for 3 or 4 years.
On Steve, about whether patented therapies such as venetoclax are available to all AML patients or only those on trial.
Yeah, thanks, Andy. So a number of these drugs are now approved by NICE. So venetoclax is the real biggie, and that was approved just in beginning of February just gone, for patients not considered fit enough for intensive chemotherapy. It can be combined with our traditional hypomethylated treatment, azacitidine. So once it's been approved by NICE, theoretically, it is approved certainly throughout NHS England. Wales then tends to follow NICE. So we've been able to use venetoclax over the last couple of months for that group of patients. And then Scotland tends to have a parallel approvals process that goes through. And I'm not absolutely sure what Northern Ireland do, but in terms of patients, so the vast majority of patients will be getting venetoclax around the UK now. One of the challenges with venetoclax is that in the early stages of the COVID pandemic, when we were trying to keep patients out of hospital and try to give alternatives to intensive chemotherapy for some patients, this was right at the beginning, the dark days of April, May 2020, we got a special agreement from NHS England that we could use venetoclax for patients that would have otherwise been fit for intensive chemotherapy in that sort of twilight area, in patients in their kind of 50s, early 60s. Apologies to anyone in their 50s and 60s who's listening to this talk. But it's kind of muddied the pitch, because we've kind of got used to using it in patients that NICE have now approved it for a different group of patients. So it's a real mess at the moment. But yes, so most of these drugs I've mentioned are approved by NICE, which all that means is that they are funded for use within the NHS.
Tumor lysis syndrome. Alan asks, how common is tumor lysis syndrome, and is there a difference between sort of AML versus solid cancers in the frequency of that?
Yeah, so tumor lysis we don't see in the majority of patients with AML. So tumor lysis tends to be seen in patients with very, very rapidly dividing tumors, and especially when we're then exposing those rapidly dividing tumors to chemotherapy and killing a lot of cells very quickly. So some people the majority of patients with AML don't have significant tumor lysis. The ones that do get it are patients who present with lots of circulating blasts in their peripheral blood, where we're having to instigate treatment on an emergency basis, and we're killing a lot of blast cells very quickly. So in that setting, it can be a problem, and it can cause kidney failure due to toxic metabolites like uric acid and high levels of phosphate going through the renal tubules. So we tend to be wise to that in advance, and we tend to try to prevent it. We've got some very good drugs for that in the last few years. We used to use xanthine oxidase inhibitors like allopurinol, which aren't all that useful, but in more recent years, in patients at very high risk of tumor lysis, we've used a drug called a rasburicase, which is actually giving the uric acid oxidase enzyme itself. So we can actually give the enzyme and break down all of the uric acid in the blood very, very quickly by doing that. So it it goes without saying it's quite an expensive drug, but it's one that we reserve for those sorts of patients. So it is common in hematologic malignancies in terms of the rapidly dividing ones, the very high-grade lymphomas and the high white count AMLs. So it's probably more common in that setting than it is in some solid cancers, actually.
Okay, and finally, there's one last one probably. What work is being undertaken in poor responder samples to find new targets? So you mentioned quite a lot of these have good outcomes for the favourable and intermediate risk groups anyway, but that does leave the sort of unmet need in those.
Yeah, so there are, I mean, first it's probably worth emphasizing there are lots and lots of targets out there that have been identified now, because I think now we've reached the end of the sort of new genome sequencing sort of area in AML. I think we're confident we've pretty much identified all the genetic mutations now that drive AML. That's obviously not the only way of targeting disease. So, I mean, there's a big translational research effort around the world identifying, using primary samples, particularly focusing on paired diagnostic and relapse samples from patients who are, by definition, not responding well to treatment if they've relapsed or had refractory disease. I mean, some of that work goes on in the AML labs in Cardiff with people like Joe and Caroline Alvarez and Alex Tonks and Richard Darley. They've got a sort of new targets in AML program that they've been working on for a few years. So there's lots of stuff going on, and there's lots of targets that are being worked up and either at the animal study stage or the early phase study stage. But I think there's enough targets to keep us going for a little while. And the challenge for the clinical trialists is backing the right one, I think, or the right combination of them.
So I've got one final question, Steve, and then we better close, which is, clearly it's a very complicated disease, and you've got a whole host of new tools and more on the way, and a host of monitoring for making treatment decisions as well. Will there become a point, or are you at a point, where it is no longer feasible for clinician, for a manual approach, and there may need to be some sort of AI-based approach for designing and stratifying patients into these trials? Because how do you choose which patient gets which treatment? How do you treatment match when you have so many options?
I think we're headed in that. I don't think we're there yet, but I think even in my sort of career, we've become much more super specialized in how we deal with these different hematologic malignancies. So we used to have fairly general hematologists who would do a bit of all cancer, we'd do a bit of myeloma, a bit of lymphoma, and a bit of acute leukemia. But I think there's been such a sort of divergence in treatment pathways and different mechanisms and drugs that we tend to be a lot more super specialized than that now. But even within that, I think we're going to be getting to the point, as I mentioned on the last slide, we're kind of heading towards a sort of bespoke treatment patient selection of different drugs. And there are algorithms and artificial intelligence things that are being produced. I mean, I know that there's been a lot of work done by people like Ellie Papamanuel and the Sanger Centre and what's called the Harmony Initiative across European sites, where they've looked at thousands of genetic samples and substratified, and now have a sort of online algorithm or an online sort of app type thing, which they're just released, where you can put all the next generation sequencing findings of your patient in at different stages of their treatment. So it's not one where you have to do it at the beginning to try to define their prognosis at different stages based on the combination of genetic lesions they've got and what sort of treatments they've had. So that's not yet at the point where a piece of paper comes out telling you which drug to give the patient, but it's probably headed that way in the years to come. Yeah.
Good stuff. Okay, well, I think we better close then for today, but just to say thank you again, Steve, for that excellent talk. And I'm sure that I speak for everybody when we wish you well in those trial developments, and we look forward to hearing about how AML 20 comes along in the next few years.
Thanks,
Okay.
Joe. Thanks, everyone.
Thanks, everybody.